Welcome to the Deep Dive, where we cut through the information overload to bring you the most critical insights. Today, we're tackling a topic that affects billions globally: malaria.
It really does. It's a disease that's often maybe misunderstood, yet it's profoundly impactful.
Absolutely. And the fight against it, well, it's a real testament to persistent scientific and public health efforts, isn't it?
It truly is. It's an ancient foe, really, as old as human civilization in many ways, yet our understanding and, importantly, our tools are constantly evolving.
Yeah, the battle really showcases humanity's incredible capacity for innovation and, maybe even more importantly, collaboration on a global scale.
Definitely.
So our mission today is to navigate the latest consolidated WHO guidelines for malaria. Think of this as your shortcut, your way into understanding the cutting-edge strategies, the challenges, and there are many, and the incredible progress being made.
Progress to control, and ultimately, the goal is to eliminate this disease.
Exactly. We're not just looking at what works, but trying to understand why it works and, the fascinating nuances behind these global recommendations.
These guidelines are really the distillation of years, decades even, of research and field experience, all rigorously evaluated to provide the most robust, evidence-based roadmap for countries.
So it's a global consensus, essentially.
Pretty much, yeah. A global consensus on how to effectively combat this parasite based on the best available science.
Okay, let's unpack this then. So what's ahead for us today? We'll explore everything from next-generation mosquito nets, the ones designed to combat evolving insecticide resistance,
Which is a huge issue.
right, to tailored drug regimens for vulnerable populations, and even the intricate dance of diagnostic testing. Getting that right is key.
Absolutely fundamental.
You'll hear about specific interventions, the certainty of the evidence backing them, which isn't always 100%, right?
Yeah.
And the real-world challenges of implementation.
Things like resource constraints, which are always a factor, and even unexpected environmental impacts that we're starting to understand better.
It's a journey into the strategic ingenuity of global health, and I think you'll find it truly fascinating. So let's start at the beginning. To really grasp the strategies, we need to understand the enemy itself. What exactly is malaria?
Right. At its core, malaria is a life-threatening disease, and it's caused by a microscopic invader protozoan parasites of the genus Plasmodium.
Okay, so not bacteria, not viruses, parasites.
Exactly, single-celled organisms. And they have this particularly nasty habit of infecting human red blood cells.
And what happens then?
Well, once they get inside, they multiply. Eventually, they burst the red blood cells, and that's what leads to the classic symptoms: the fever, the chills, that awful flu-like illness.
And if it's left untreated?
That's when it can escalate. Severe complications affecting vital organs, the brain, kidneys, lungs. And tragically, it can, and often does, lead to death without prompt treatment.
And how do these microscopic invaders actually get from one person to another? I'm assuming there's a vector involved, like with many tropical diseases?
You're absolutely right. The critical link in this chain of transmission is the adult female Anopheles mosquito, only the females.
Why only the females?
They need the protein from a blood meal to develop their eggs. The males just feed on nectar. So these female mosquitoes act as vectors. They pick up the Plasmodium parasites when they feed on an infected human.
Okay.
The parasites then develop inside the mosquito. Takes about a week or so, depending on temperature. Then they migrate to the mosquito's salivary glands.
Ready to infect the next person.
Precisely. During a subsequent blood meal on another human, the mosquito injects those parasites along with its saliva, starting a new infection. So, understanding this specific vector, its biology, its biting habits, when it bites, where it rests, that's fundamental to almost all our prevention strategies.
Break the chain.
If we can break that link, yeah, we can stop the spread.
So it's a mosquito-borne parasitic disease. That clarifies a lot already. But are all malaria parasites the same, or are we dealing with different species? You mentioned the genus Plasmodium.
That's a really crucial question, because this is where the complexity truly ramps up. While Plasmodium falciparum is probably the most infamous.
That's the one you hear about most often, causing severe malaria.
Exactly. It's notorious for causing the most severe, often fatal form of malaria, but it's definitely not the only player. We also have P. vivax.
And what's special about Vivax?
P. vivax presents a unique challenge because it can form dormant stages in the liver. They're called hypnozoates.
Hypnozoates,
Yeah.
like sleeping parasites.
Sort of, yeah. They can lie in wait for weeks, months, even years after the initial infection seems to be treated and cleared from the blood. Then suddenly they reactivate and cause relapses.
Wow, so you think you're cured, but you're not.
Exactly. It makes P. vivax incredibly persistent and much more difficult to eradicate completely from a person and from a population.
Are there others besides Alciparum and Vivax?
Yes, there are others like P. ovale, which also has liver stages like Vivax. Then there's P. malaria, which can cause very long-lasting chronic infections, and P. knowlesi, which is primarily found in Southeast Asia and can progress very rapidly to severe disease.
So it's not just one disease, it's really a family of diseases.
It's a good way to put it, each demanding its own nuanced response in terms of diagnosis, treatment, and control strategies.
Wow, okay. That definitely complicates the global effort.
Yeah.
With such a multifaceted enemy, what's the overarching strategy? Is there a global vision for tackling malaria?
There absolutely is. The main blueprint guiding global efforts is the WHO's Global Technical Strategy for Malaria 2016-2030. We usually just call it the GTS.
The GTS. And it's not just wishful thinking.
No, not at all. It isn't just an aspirational document. It lays out very concrete, time-bound goals, milestones, and targets for countries worldwide. It's a really comprehensive framework.
Okay, so what are those main goals? What's the GTS aiming to achieve by 2030?
It focuses on two main interconnected objectives. First, significantly reduce malaria morbidity. That's the sickness and mortality rates globally. Fewer people getting sick, fewer suffering severely, and crucially, fewer people dying.
Makes sense. And the second objective?
The second is progressive elimination. Systematically eliminating malaria from countries where it was still transmitted back in 2015. It's about not just controlling the disease everywhere, but actually getting rid of it, country by country, region by region.
That sounds incredibly ambitious.
Yeah.
Elimination by 2030. Given how long malaria has been around, has there been tangible success that shows this is even within the realm of possibility?
Yes, and this is where we see the immense power of coordinated global health initiatives when they're well-funded and implemented. Between 2000 and 2015, for instance,
Okay.
the prevalence of P. falciparum infection in endemic Africa was actually halved, cut by 50%.
Wow.
And even more impressively, the incidence of clinical disease people actually getting sick across the continent fell by 40%.
That's huge.
It is. During that period, key interventions like bed nets and better treatment averted an estimated 663 million clinical cases just in Africa.
663 million cases averted. That's staggering.
It really puts it in perspective, doesn't it? Hundreds of millions of people who didn't suffer from malaria, weren't hospitalized, whose lives weren't tragically cut short. It's a powerful demonstration of what's achievable.
Okay, that's genuinely inspiring. But you mentioned earlier that malaria transmission is really varied. It fluctuates by season, by year, even over small distances like village to village. So how can global guidelines be effective? Doesn't a one-size-fits-all approach risk being inefficient?
You've hit on an absolutely critical point, and it's one the guidelines explicitly address. Malaria transmission is highly heterogeneous. It's incredibly diverse, patchy, non-uniform.
Right.
So a blanket one-size-fits-all approach simply won't work. It would be wasteful and ineffective in many places. So the guidelines provide a robust framework for tailoring interventions, adapting them to specific local contexts.
So how do they approach this tailoring? What kind of metrics or categories do they use?
They use what's called stratification categories, basically classifying geographical areas, districts, regions based on their local malaria transmission intensity.
Can you give an example?
Sure. For instance, high transmission areas might be defined as having an annual parasite incidence of 450 or more cases per 1,000 people, with P. falciparum prevalence surveys showing 35% or higher infection rates in kids.
Okay.
Then you have moderate transmission, maybe 250 to 450 cases per 1,000, prevalence 10 to 35%. And low transmission, say 100 to 250 cases, prevalence 1 to 10%. And even very low transmission below that.
And these aren't just academic labels. They actually guide decisions.
Absolutely. They directly inform which interventions are most appropriate, most cost-effective, and likely to have the biggest impact in that specific setting. It's about knowing your specific battleground in detail.
I see. So this really emphasizes a kind of problem-solving approach, doesn't it? Moving beyond rigid prescriptions to more data-driven choices.
Exactly. That's a key shift highlighted in these latest guidelines. moving away from overly prescriptive top-down recommendations, everyone must do X, to what they term a problem-solving approach.
Agreed.
It means deeply engaging with local data, surveillance data, survey data, entomological data about the mosquitoes to identify the most relevant and impactful interventions for specific subnational contexts. Even within a country, you might need different strategies in different districts.
Why is this shift so crucial?
Because in many, if not most, endemic countries, resources are scarce. Very scarce. Every dollar, every health worker's hour needs to be precisely targeted to ensure maximal impact and avoid wasting precious funds and effort.
So it demands better data systems.
Absolutely. This approach demands robust surveillance systems, strong capacity for data analysis at local levels, and a deep understanding of the local epidemiology to adapt the response effectively and efficiently. You wouldn't fight a fire without knowing where it started or how big it is, right? It's all about precision targeting.
That makes perfect sense. Strategic precision based on local intel. Okay, now that we understand the landscape, let's move into the front line of defense. Prevention. For many of us, when we think malaria prevention, the first image is probably a mosquito net. How big a deal have these really been?
Insecticide-treated nets, or ITNs, have been nothing short of monumental, truly a game changer in the fight against malaria.
Monumental how? Can you quantify that?
Well, remember that figure about averted cases? ITNs are credited with averting a staggering 68% of the clinical malaria cases in Africa between 2000 and 2015, the vast majority of that progress.
68%. That's incredible. How do they work so well?
Their genius lies in a dual protection mechanism. First, personal defense. They form a physical barrier, keeping mosquitoes away from the person sleeping under them. Pretty straightforward.
Right.
But second, and just as important, is the community effect. The insecticides on the nets kill or at least incapacitate mosquitoes that land on them trying to bite. This reduces the overall mosquito population density in an area and shortens their average lifespan.
So fewer mosquitoes overall, and the ones that are around don't live long enough to transmit the parasite easily.
Exactly. Fewer mosquitoes, fewer infectious bites, less transmission across the whole community, even for those who might not be using a net perfectly every night.
But I've heard, and you mentioned it earlier, issues with mosquitoes developing resistance to the insecticides. Is that a major hurdle now, threatening how well these nets work?
It is a very significant challenge, yes. It's forced a critical evolution in ITN technology. The widespread use of ITNs, particularly those treated only with pyrethroids.
Pyrethroids, that was the main insecticide class used.
Historically, yes. They were effective, relatively safe, and affordable, but their extensive use exerted huge selection pressure on mosquito populations. Naturally resistant mosquitoes survived and passed on their genes.
Survival of the fittest, mosquito addition?
Pretty much. This resistance meant we couldn't just keep deploying the same old pyrethroid-only nets and expect the same results. Researchers and manufacturers had to innovate, leading to the development of what we call next-generation ITNs.
Okay, so what are these next-gen nets? What clever solutions have they come up with to get around this pyrethroid resistance?
There are a few key advancements that are now strongly recommended in the guidelines. First, we have pyrethroid PBO ITNs.
PBO, what's that?
PBO stands for piperonal butoxide. It's not actually an insecticide itself, it's what we call a synergist.
A synergist? Like a booster?
Exactly like a booster shot for the pyrethroid insecticide. It works by inhibiting certain enzymes in the mosquito, often called monooxygenases, which the mosquito normally uses to detoxify or break down the pyrethroid.
So PBO stops the mosquito's defense mechanism.
That's the idea. It neutralizes the mosquito's metabolic resistance, allowing the pyrethroid to remain effective even against mosquito populations that have developed that specific type of resistance. These nets have a strong recommendation, backed by moderate certainty evidence.
But there are considerations.
Yes, malaria programs need to assess their local resistance patterns. Is this the type of resistance PBO works against? And they also need to make sure they have the resources for the slightly higher cost of PBO nets compared to the old pyrethroid-only ones.
Okay, that's a clever way to outsmart the mosquito's evolving defenses. What else is there?
Next, there are pyrethroid chlorphenapyr ITNs. Chlorphenapyr is a different class of insecticide altogether with a different mode of action. Combining it with a pyrethroid offers another way to tackle resistance.
And how effective are these?
They also receive a strong recommendation with moderate certainty evidence, specifically for areas with pyrethroid resistance. Studies, for example, in Benin and Tanzania have shown really impressive results. Significant reductions in clinical malaria incidence.
Like how much?
A rate ratio of 0.44 at 1 year. That means nearly a 60% further reduction in cases compared to using pyrethroid-only nets in the same resistant environment. And similar reductions in malaria infection prevalence. A clear, substantial improvement in protection.
That is a clear win. Is there a third type of these new nets?
Yes, a third type mentioned is pyrethroid pyriproxyfen ITNs. Pyriproxyfen is an insect growth regulator. It messes with mosquito reproduction and development. These are conditionally recommended as an alternative to pyrethroid-only nets in resistant areas.
Conditionally. So there's a catch.
There's a crucial caveat, yes. They are not recommended over the pyrethroid PBO ITNs.
Why not, if they also combine two things?
Primarily due to concerns about poorer cost-effectiveness. They tend to be more expensive, and the evidence suggests their additional protective impact might be relatively shorter-lived, maybe around 12 months, compared to the pyrethroid PBO nets, which might offer longer-lasting enhanced protection.
Ah, okay, so choosing the right type of new net isn't simple. It's a really nuanced decision.
It is. Based on local mosquito resistance profiles, the specific mechanisms of that resistance, the relative costs, resource availability, and the expected duration of efficacy for each type. It's complex operational research informing policy.
So it's not just about getting nets out there, but getting the right nets out there. What about the practicalities? Distribution and something you hinted at earlier, disposal.
Deployment and disposal are crucial, often overlooked, parts of the whole ITN life cycle. For distribution, the standard recommendation for mass campaigns is to aim for universal coverage, which often translates to 1 ITN per 1.8 persons.
1 per 1.8. Why the decimal?
It's a planning figure that helps account for households with odd numbers of people, ensuring you get closer to everyone having access to a net. And ideally, these mass campaigns should be repeated every 3 years as the nets wear out and the insecticide fades.
And in emergencies?
In humanitarian emergencies, think refugee camps, conflict zones where populations are highly mobile, vulnerable, and living conditions are often poor, more frequent distribution might be justified. The guidelines strongly emphasize ITNs for prevention in these settings too.
But it must be harder there.
Much harder. Logistical capacity, damaged infrastructure, security issues, reaching everyone all need meticulous planning and adequate resources, which are often stretched thin in emergencies.
Okay, now, the plastic problem. That really caught my attention earlier. Tell me more about that.
Yeah, this is one of those really eye-opening, almost paradoxical insights. ITNs, while saving literally millions of lives, are made of polyester or polyethylene treated with insecticide. And they contribute approximately 100,000 tons of plastic waste annually just in Africa.
100,000 tons.
It's a huge amount. So put it in perspective, that's about 200 grams of insecticide-treated plastic per person per year in endemic areas receiving nets. The critical issue isn't just the plastic, but that it's insecticide-treated plastic.
Posing an environmental risk if not handled properly.
Exactly. Proper disposal methods are absolutely essential. High-temperature incineration is the best option, as it safely breaks down both the plastic and the chemicals.
What if incineration isn't available? Which it often isn't, I imagine.
If it's not feasible, the nets should be carefully buried in designated pits, away from water sources, rivers, wells, groundwater, ideally in non-permeable soil. This is because residual insecticide can leach into the environment and be highly toxic to aquatic organisms, especially fish.
And burning them in the open. People might think that's a good way to get rid of them.
That's explicitly not recommended. Burning them in the open air at low temperatures doesn't destroy the insecticide properly and can release toxic fumes. It's a fascinating and quite sobering example of the unintended consequences in global health. A life-saving tool creates a substantial environmental burden that demands its own innovative solutions for waste management.
Wow, the environmental angle is definitely something to think about. It really underscores the depth of these challenges. Okay, so beyond nets, what's the next major prevention strategy in the WHO's arsenal?
The next major pillar of vector control is indoor residual spraying, or IRS.
IRS, so spraying inside houses.
That's right. It involves applying a long-lasting liquid insecticide formulation to the interior surfaces of buildings, usually the walls and ceilings, anywhere mosquitoes might land and rest after they've taken a blood meal.
And the goal is to kill them after they bite, before they can bite someone else.
Exactly. The goal is to kill mosquitoes that come into contact with the treated surfaces, preventing them from surviving long enough for the malaria parasite to develop inside them and be transmitted onwards. It shortens the lifespan of the vector population.
So it's about treating the houses themselves. What are the ideal conditions for IRS to be most effective? Where does it work best?
IRS is considered most appropriate and impactful under specific conditions. Firstly, the local Anopheles mosquitoes need to primarily feed and, crucially, rest indoors. If they bite you and fly straight outside, IRS won't do much.
Okay, makes sense.
Secondly, people in the area need to mainly sleep indoors at night when the main malaria vectors are typically biting. Thirdly, the local malaria transmission patterns should allow for adequate protection with just 1 or 2 rounds of spraying per year. If transmission is year-round and intense, you might need more frequent spraying, which gets expensive and logistically difficult.
And the houses themselves.
And finally, the majority of structures in the targeted area need to be suitable for spraying, meaning they have walls and ceilings made of materials that can effectively hold the insecticide for several months. Spraying mud walls is very different from spraying painted concrete.
Got it. So specific conditions are needed. Now, I can see how combining nets and spraying might seem like the obvious belt and braces approach for maximum protection, but the guidelines actually advise against doing both everywhere, right?
You're absolutely correct, and this is a crucial point about resource allocation and efficiency. The guidelines generally recommend focusing efforts and resources on achieving high-quality implementation and coverage of either ITNs or IRS in a given area, rather than broadly deploying both interventions simultaneously in the same households or communities.
Why is that, if both work?
It's primarily driven by the resource constraints faced by most malaria endemic countries. Doubling up on major vector control interventions is very expensive. And while co-deployment might be considered in very specific situations,
Like what?
for instance, as part of an insecticide resistance management strategy, perhaps alternating or rotating interventions, but only if sufficient additional resources are available. Generally speaking, the evidence suggests that co-deployment has limited additional utility in reducing malaria morbidity and mortality when one of the interventions, like ITNs, is already achieving optimal coverage and is proving effective against the local vectors.
So the added benefit often doesn't justify the significant added cost.
Exactly. The marginal gain might be small compared to the cost. It's about making smart, efficient choices with limited funds to achieve the biggest public health impact. Focus on doing one thing well rather than 2 things perhaps less well.
Okay, that makes sense from a resource perspective. But how effective is IRS on its own, really? And what are some of its challenges beyond just cost?
Historically, IRS has been shown to be very efficacious in specific contexts. The original malaria eradication campaigns relied heavily on it. However, assessing its current impact in complex settings is tricky. A recent systematic review actually found only very low certainty evidence for IRS's direct impact on malaria incidence, compared to no spraying in some modern settings, with an incidence rate ratio around 4.90.
Only a 10% reduction, maybe. That sounds low.
It does sound low, but it doesn't necessarily mean IRS doesn't work. It reflects the difficulty of conducting truly randomized, high-quality trials for large-scale public health interventions like this. Often the comparison is IRS versus nets, not IRS versus nothing, which makes showing a huge additional benefit hard.
What about other challenges? Acceptability.
Yes, challenges also extend to community acceptability, which can be a major factor. People might object to having their homes sprayed. Common issues include temporary wall discoloration from the spray, sometimes lingering bad smells, especially historically with DDT. Some communities report an increase in nuisance pests like bed bugs after spraying, maybe because the insecticide affects predators. And there are always concerns about potential contamination of food, water, or cooking utensils if spraying isn't done carefully.
And in emergencies.
Deploying IRS in humanitarian emergencies also comes with significantly higher logistical costs. You need trained spray teams, specialized equipment, insecticide procurement and management, safe storage, transport, all in potentially unstable or hard-to-access areas. It's complex.
You mentioned DDT earlier. That's the really well-known but also very controversial insecticide because it lasts so long in the environment. Is it still used for malaria control?
That's an important question. The WHO supports the use of alternatives to DDT whenever possible, and its use for malaria vector control has significantly declined globally over the years, which is good news for the environment.
But it's not banned entirely.
It's not banned under the Stockholm Convention for Public Health Use, specifically for malaria control, but its use is restricted. While it might still be considered warranted in very specific, carefully assessed situations where other effective options are simply not available due to complex insecticide resistance patterns.
It requires strong justification.
Absolutely. Any decision by a country to use DDT requires a detailed scientific analysis, stakeholder consultation, and clear, compelling reasoning demonstrating why it's necessary over other available pre-qualified insecticides. The emphasis is always on using the least harmful effective option based on local vector susceptibility and environmental safety assessments.
Okay, so ITNs and IRS are the heavy hitters. But the toolkit doesn't stop there, right?
Hmm.
Are there other, maybe newer or more niche vector control innovations the guidelines cover?
Yes, the guidelines are constantly evolving and explore several other intriguing vector control innovations. This reflects the continuous search for new tools, especially with the challenge of resistance. One of the newest additions, with recommendations finalized around 2025, is spatial emanators.
Spatial emanators. What on earth are those?
They are devices designed to release active ingredients, often repellent or insecticidal compounds, slowly into the air over time. The idea is to create a kind of protective bubble or zone within a defined space, like a room or even around a house.
So they deter mosquitoes from even entering the space or disrupt their biting.
Exactly. They might repel them or confuse their host-seeking behavior, or even kill them if the concentration is high enough. They receive a conditional recommendation with moderate certainty evidence.
Conditional. So where would they fit in?
They're seen primarily as a supplementary measure, designed to be deployed alongside primary interventions like ITNs or IRS, especially where those primary tools face limitations.
For example,
Think about humanitarian emergencies again, where people might be displaced, sleeping outdoors, or in temporary shelters unsuitable for nets or spraying. Or maybe in areas where people spend a lot of time outdoors during biting hours. Studies have shown they can significantly reduce malaria incidence. One meta-analysis suggested about 472 fewer cases per 1,000 people exposed, particularly when deployed with consistently high coverage.
that sounds promising, like a localized invisible shield. But I imagine, as with all new tech, there are downsides or concerns.
There are indeed. Concerns include the initial cost of the devices, their effective lifespan, how long do they keep working, and the logistics of distributing them widely and ensuring people use them correctly and continuously. High coverage is key.
Any potential risks?
Potential risks include the possibility of mosquitoes simply being diverted from treated spaces to untreated ones nearby, potentially increasing risk there. There's the environmental waste from discarded devices, potential fire hazards depending on the device type, and, as always with insecticides, the potential for resistance developing to the active ingredients if they're not managed carefully within broader resistance management strategies.
Okay, another tool, but with caveats. What about more structural changes, making houses themselves more mosquito-proof?
You're referring to house screening. This received a conditional recommendation back in 2021, though based on low certainty evidence at the time.
So literally putting screens on windows and doors.
Yes, and also screening ceilings, closing eaves gaps, basically physically blocking mosquito entry points. Programs considering this need to carefully assess local contextual factors. Is it feasible to install screens on the types of houses common in the area? Who will maintain them? Are the resources available for large-scale implementation and upkeep? It's about physically excluding the mosquitoes.
And then there's a strategy that targets mosquitoes even before they become flying adults, attacking them in the water.
That's larval sork management, or LSM. This is all about attacking the mosquito at its immature stages, eggs, larvae, and pupa, while they're confined to water bodies, preventing them from ever developing into biting adults.
How do you do that? What are the methods?
LSM encompasses several different approaches. There's habitat modification, making permanent changes to the environment, like draining swamps, filling in ditches, land reclamation. Then habitat manipulation, recurrent activities like flushing streams, clearing vegetation from pond edges, regularly emptying artificial water containers.
Like getting rid of standing water around homes.
Exactly. Then there's larviciding, applying chemical or biological insecticides directly to water bodies where larvae are found. And even biological control, like introducing larvivorous fish that eat mosquito larvae into ponds or reservoirs.
Attacking the mosquitoes in their nurseries, essentially.
Yeah.
Where does this approach make the most sense?
LSM is generally considered best suited for areas where mosquito breeding sites are relatively few, fixed, and findable.
Few, fixed, and findable.
Meaning the water bodies where mosquitoes breed are limited in number, don't move around much, and are easy to identify and access for treatment. This is often the case in urban settings or arid areas where water sources are concentrated. It can effectively reduce the density of adult mosquitoes emerging.
But it's not a standalone solution.
No, and this is crucial. LSM is not seen as a substitute for ITNs or IRS, which provide direct protection against biting adult mosquitoes. LSM is a supplementary strategy. It tackles the problem upstream, but you still need protection from the adult mosquitoes that do emerge or fly in from elsewhere.
That distinction is really important. Now, are there any other interventions that have been looked at but are generally not recommended by WHO for community-level malaria control, things people might think would work?
Yes, the guidelines also explicitly mention interventions that are conditionally recommended against for broad public health use. For instance, topical repellents like the sprays or lotions you might use when traveling.
Why aren't they recommended for communities? They protect individuals, right?
Right. They can offer individual protection, maybe for specific high-risk groups like forest workers or soldiers who are outdoors a lot. But for community-level control, they lack significant population impact. Why? Because achieving the necessary extremely high, consistent, and correct usage by everyone in a community every single night or biting period is practically impossible to sustain. Compliance is the killer.
Okay, that makes sense. What else is not recommended?
Similarly, insecticide-treated clothing is conditionally against for general malaria prevention programs. And space spraying, also known as fogging, where insecticide mist is sprayed into the air to kill flying adult mosquitoes.
You see that sometimes in towns.
You do, but it's conditionally against as a primary malaria control tool. This is due to a lack of robust evidence showing a significant sustained impact on malaria transmission, combined with its high operational costs and very short-lived effects. It only kills the mosquitoes present at that exact moment.
So for all these, the message is focus resources elsewhere.
Pretty much. The guidelines consistently prioritize interventions like ITNs and IRS, and now maybe these newer tools like PBO nets or chlorphenapar nets, because they have proven effectiveness, are scalable and represent a better use of limited public health resources for achieving broad impact. Focus on what works best and what works efficiently at scale.
Right. Strategic allocation of scarce resources. It keeps coming back to that. We've talked a lot about stopping transmission through vector control nets, spraying, larviciding. Now let's explore a more proactive approach using medicines. Chemoprevention, using drugs to protect against malaria before someone gets sick. But first, let's clarify some terms that sound really similar. What's the difference between chemoprevention and chemoprophylaxis?
Yes, that's an important distinction, especially in the context of these guidelines. Chemoprevention, as defined here, involves giving full therapeutic courses of anti-malarial medicines at pre-scheduled times. This is done regardless of whether a person is currently known to be infected.
Full courses?
Yeah.
Even if they feel fine. Why?
The goal is twofold. First, to treat any existing, perhaps low-level or asymptomatic infections the person might have. Clear the decks, so to speak. Second, to prevent new infections from taking hold during the period the drug levels are protective. This strategy is primarily aimed at people living in endemic areas, particularly those in vulnerable groups.
Okay, so full doses for treatment and prevention in residents. What about chemoprophylaxis then? That's the term travelers often hear.
Exactly. Chemoprophylaxis typically uses subtherapeutic doses of antimalarial medicines, or sometimes regular therapeutic doses taken very frequently, like daily or weekly. Its main purpose is purely to prevent new infections from establishing themselves. And it's primarily used for non-immune individuals, mostly travelers going to endemic areas for a limited period.
So these WHO guidelines for endemic populations are focused squarely on chemoprevention, using those full therapeutic courses.
Correct. For the strategies aimed at residents, especially vulnerable groups within endemic areas, the term used and the approach described is chemoprevention.
Okay, that makes the distinction much clearer. So who are these vulnerable groups who receive chemoprevention, and how are these protective strategies tailored for them?
The guidelines outline several key, highly targeted strategies. First, there's intermittent preventive treatment in pregnancy, or IPTP. This is a cornerstone intervention.
IPTP for pregnant women. How does that work?
It's a strong recommendation backed by moderate to high certainty evidence. Pregnant women receive doses of a specific drug combination, sulfadoxine pyrimethamine or SP. They get these doses at least 1 month apart, starting after the first trimester, with the objective of ensuring they receive at least 3, preferably more doses during their pregnancy.
How is it delivered? Through clinics.
Primarily, yes. It's typically delivered via routine antenatal care, or ANC, contacts. This integrates malaria prevention seamlessly into maternal health services. However, recognizing that not all women access ANC consistently.
Right, there can be inequities.
Exactly. So the guidelines also suggest exploring other delivery methods where needed, like using community health workers, CHWs, to ensure wider reach and equity.
And the impact. Is it significant?
Hugely significant. IPTP is generally highly cost-effective, widely accepted by women in communities, and feasible to implement through existing health systems. It significantly reduces maternal anemia, placental infection, low birth weight, and maternal malaria infection at delivery. Healthier mothers, healthier babies. It's a proven high-impact intervention.
That sounds incredibly valuable. What about young children? They're also extremely vulnerable to severe malaria, aren't they?
Absolutely. Infants and children under 5 bear the brunt of severe malaria and mortality. So there are specific strategies for them too. One is perennial malaria chemoprevention, or PMC.
Perennial, meaning year-round.
Yes, this is for children in age groups at high risk of severe malaria, living in areas with moderate to high perennial transmission, meaning malaria is a threat pretty much all year round, not just seasonally. This is a conditional recommendation with moderate certainty evidence.
Who gets PMC? Just infants.
It used to be primarily focused on infants under 12 months and was often called IPTI, intermittent preventative treatment in infants. But newer evidence has shown its value extends to children aged 12 to 24 months as well, so the term PMC is broader now. SP, the same drug as in IPTP, is widely used.
And how is PMC delivered to these young kids?
Delivery via the Expanded Program on Immunization, or EPI, platform basically, giving the dose during routine vaccination visits has proven crucial for both cost-effectiveness and community acceptance. Parents are already bringing their children for shots.
Makes sense. And the benefits?
PMC probably reduces clinical malaria incidence, reduces moderate to severe anemia, reduces all-cause hospital admissions, and critically likely reduces all-cause mortality in these young children during the period they receive it.
Okay, so that's for year-round transmission.
Mm-hmm.
But many places have very distinct rainy seasons where malaria peaks.
Exactly. And for those areas, there's seasonal malaria chemoprevention, or SMC. This is a strong recommendation with moderate certainty evidence.
How does SMC differ from PMC?
SMC involves giving anti-malarial medicines, usually a combination of SP plus amodiaquin, another anti-malarial, to children at high risk of severe malaria, but only during the peak transmission season, typically the 3, 12, 5 months of highest risk each year. Its suitability depends heavily on having a clearly defined malaria season and, of course, funding availability.
And its impact.
SMC has been shown to be highly effective, significantly reducing clinical malaria incidents, severe malaria cases, anemia, and all-cause hospitalizations among children under 5 during those high-risk months.
What about drug resistance? Giving drugs seasonally like that, does it pose a risk?
That's a legitimate concern, and it's closely monitored. However, current evidence suggests that SMC, when implemented correctly with good adherence, does not inevitably lead to a major increase in resistance to the drugs used. It seems the benefits in saving lives and reducing illness currently far outweigh the observed risks of resistance, but vigilance is key. Direct observation of treatment, where a health worker actually watches the child take the first dose each month, helps improve adherence.
These interventions seem very focused on the under 5s. What about older school-age children? Are they still considered vulnerable enough for chemoprevention?
That's a good question. There's a strategy called intermittent preventative treatment in school-age children, or IPTC. This is a conditional recommendation, but notably with low certainty evidence currently.
Who is it for, and what does it aim to do?
It's been evaluated for children aged roughly 5 to 15 years. The thinking is that while they might be less likely to die from malaria than infants, they still suffer significant illness, anemia, and miss school, and can contribute to the parasite reservoir. IPTC may reduce clinical malaria, anemia, and P. falciparum parasite prevalence in this age group.
And how would it be delivered?
Schools offer a potentially very low-cost and accessible delivery channel, which is a major advantage. However, programs need to carefully consider things like, does the malaria season align with school terms? What about children who don't attend school? How do you ensure equity? Alternative delivery methods might be needed.
So it's less of a priority than protecting the under 5s.
Generally, yes. Given limited resources, prioritizing chemoprevention for younger children under 5 years remains paramount, as they are at the highest risk of severe outcomes. IPTSC is more of a potential supplementary intervention where resources allow, and the burden in that age group is significant.
Okay. What about children after they've been hospitalized, say with severe anemia, which is often linked to malaria? Are they particularly vulnerable afterwards?
They are extremely vulnerable in the weeks and months following discharge. That leads us to post-discharge malaria chemoprevention, or PDMC.
PDMC, tell me about that.
This is a conditional recommendation with moderate certainty evidence. It's specifically for children following hospital admission with severe anemia, importantly. Severe anemia not related to trauma, surgery, cancer, or a known bleeding disorder, implying it's likely infection-related in areas with moderate to high perennial transmission.
And what does PDMC involve?
It involves giving them a course of effective antimalarials after they leave the hospital to prevent relapse or reinfection during that high-risk recovery period. PDMC has been shown to reduce the risk of readmission for severe malaria and also reduces all-cause mortality during the intervention period.
How is it best delivered? Back at the hospital.
Interestingly, community-based delivery, perhaps by a CHW visiting the home, is preferred over asking caregivers to bring the child back to the facility. Why? It's associated with better adherence, and it's more cost-saving for families due to reduced travel costs and time off work. It's about continuing that protection seamlessly when children are most vulnerable.
So we've covered these incredibly important targeted chemoprevention strategies for specific vulnerable groups. Now, let's broaden the scope a bit and talk about what the guidelines call mass strategies. What's the deal with mass drug administration, or MDA, and something called mass relapse prevention, or MRP?
Right, these are interventions applied much more broadly. Mass drug administration, or MDA, involves providing a full therapeutic course of antimalarial medicine to the entire population of a defined geographical area, everyone living there all at roughly the same time, regardless of whether they have symptoms or tested positive.
Like a blanket treatment for a whole town or district. What's the goal?
The intent is usually to rapidly reduce the overall parasite reservoir in the community, interrupting transmission or significantly lowering the burden of disease very quickly.
Does it work? What are the specific recommendations for MDA?
It's nuanced. For burden reduction of P. falciparum in areas with moderate to high transmission, MDA receives a conditional recommendation. It can provide short-term reductions in disease burden, typically lasting maybe 1 to 3 months. But, and this is crucial, it absolutely must be implemented as part of a robust, comprehensive malaria control program that includes strong vector control and case management. It's not a magic bullet on its own.
And in emergencies.
It's also conditionally recommended in emergency settings, like after a natural disaster or in complex humanitarian situations, where health systems are disrupted and a rapid reduction in malaria burden is paramount to prevent outbreaks.
Okay, what about using MDA not just to lower the burden, but to actually try and stop transmission altogether, maybe in areas getting close to elimination?
For transmission reduction of P. falciparum in very low to low transmission settings, aiming for elimination, it's also a conditional recommendation, but backed by low certainty evidence for achieving a sustained long-term effect.
Why the uncertainty?
There are significant concerns about the sustainability of the impact, especially if only 1 or 2 rounds of MDA are conducted. Once the drug effect wears off, transmission can rebound if underlying factors aren't addressed. Plus, MDA requires substantial financial and logistical resources. Reaching everyone is a massive undertaking.
And what about MDA for PV-vax? That seems even trickier with the relapse issue.
It is much trickier. For PV-vax, the evidence base for MDA is notably weak and often conflicting. MDA using standard antimalarials without an acetaminophen drug, the type needed to clear those dormant liver stages.
The hypnozoes.
Right. Without tackling the hypnozoites, MDA for Vivax likely only has a very short-term impact on blood stage infections, doing little to prevent future relapses, which drive much of the Vivax burden. Programs considering MDA for Vivax need to very carefully think about how to safely and feasibly administer treatment that prevents relapses, which brings us to the next point.
Which is mass relapse prevention, or MRP.
Exactly. This specifically refers to strategies aiming to clear those P. Vivax hypnozoites on a mass scale. And here, the guidelines have a very important conditional recommendation against mass treatment with an 8-aminophenolin medicine alone, like Primaquine, without first testing individuals for G6PD deficiency.
G6PD deficiency. We touched on this with treatment, but why is it such a barrier for mass treatment? Why the strong recommendation against doing it without testing?
The reason is critical: the potential for severe harm. Individuals with glucose-6-phosphate dehydrogenase, or G6PD, deficiency, a common genetic condition, can suffer severe hemolysis, which is the rapid destruction of their red blood cells, if they take standard doses of 8-aminoquinolines like Primaquine or Tafenquine.
So giving the drug widely without testing could seriously harm some people.
Precisely. The potential for severe adverse events, even death in some cases, is significant. Now, imagine trying to roll out G6PD testing for an entire population before administering the drug. The operational complexity, the cost of tests, the time involved, ensuring quality testing everywhere, it adds substantial hurdles.
So it's a major safety concern balanced against logistical difficulty.
Yes. The guideline development group weighed the potential population benefit of preventing relapses against the very real risk of severe harm to G6PD deficient individuals if testing isn't done or isn't done reliably. Given that risk and the operational challenges, mass administration of these drugs without testing was recommended against. It highlights that very difficult ethical and practical balance in public health.
That's a powerful example of how complex these large-scale interventions are, balancing potential gains against potential harm and the sheer practicality of doing things safely on the ground. So far, we've focused heavily on stopping the spread and preventing infection through vector control and chemoprevention, but inevitably, people still get malaria. So let's move into case management. What happens once someone is suspected of having malaria? How important is getting the diagnosis right?
Precision in diagnosis is absolutely paramount. It's really a foundational principle of good malaria case management. The golden rule, according to WHO, is that all suspected malaria cases should be confirmed with a parasitological test.
A test, not just based on symptoms.
Not just symptoms, no. Because fever can be caused by many things, especially in endemic areas. So a parasitological test, either microscopy or a rapid diagnostic test, an RDT, should be done, ideally within 2 hours of the patient presenting to a health facility or community health worker.
Within 2 hours. Why the urgency?
Several reasons. Firstly, it prevents the overtreatment of malaria. Giving powerful anti-malarial drugs to people who don't actually have malaria is wasteful, exposes them to unnecessary side effects, and crucially, fuels the development of drug resistance.
Right, the resistance issue again.
Secondly, it ensures that patients who do have malaria receive the correct treatment promptly, which leads to better clinical outcomes and reduces the chance of progression to severe disease. And thirdly, if the malaria test is negative, it prompts the health worker to look for the actual cause of the fever. It's about getting the right diagnosis and the right treatment to the right patient fast. Test and treat.
Test and treat. Okay. What are the specific strengths and weaknesses of the two main diagnostic methods you mentioned, microscopy versus RDTs?
Let's start with microscopy. Looking at a stained blood smear under a microscope. When performed by a skilled, experienced microscopist, it's a really powerful tool.
What can it tell you that an RDT might not?
It allows for accurate parasite counting or quantification. This is critical for identifying hyperparasitemia, a very high parasite load, which is a sign of severe disease and poor prognosis. It also enables precise species identification. Is it falciparum, vivax ovale, malaria? This is vital for guiding treatment, especially the need for anti-relapse therapy for vivax and ovale. Microscopy can also provide prognostic information in severe malaria by looking at parasite stages, and it allows for monitoring the patient's response to treatment over time by seeing if parasite counts are falling.
Sounds great, but what are the downsides?
The main limitations are that it requires well-trained, proficient staff. Maintaining that skill takes practice and quality control. It needs good quality reagents, stains, clean slides, a well-maintained microscope, and often reliable electricity. These aren't always available, especially in remote, resource-limited settings. It also takes time preparing the slide, staining, reading it carefully.
Okay, so that's where RDTs come in, the rapid tests.
Exactly. Rapid diagnostic tests, or RDTs, have been a massive game changer for diagnosis, particularly at the community level and in primary care settings where microscopy isn't feasible. They provide a result usually within 15-20 minutes.
How do they work?
They typically detect specific malaria parasite antigens proteins produced by the parasite in a drop of the patient's blood. Most common RDTs detect HRP2, which stands for histidine-rich protein 2, a protein produced abundantly by P. falciparum. Some RDTs also include a test for a different antigen, like PLDH, parasite lactate dehydrogenase, which can help detect non-falciparum species, though often with lower sensitivity.
So they're quick and easy. Are they as accurate as microscopy?
RDTs detecting HRP2 for P. falciparum are generally highly sensitive and specific, performing very well in most settings. However, they do have limitations. As mentioned, sensitivity for non-falciparum species like P. vivax can be lower. A huge operational issue is deletions in the HRP2 gene in some P. falciparum parasite populations, particularly in parts of South America, Africa, and Asia. If the parasite doesn't produce HRP2, the RDT will be falsely negative. This needs careful monitoring.
False negatives, that's a worry. Any other limitations?
Another key limitation, especially for HRP2-based RDTs, is that they are not suitable for detecting treatment failures soon after treatment. Why? Because the HRP2 antigen can persist in the patient's bloodstream for weeks, even after the parasites have been successfully cleared by treatment.
So a positive RDT a week after treatment doesn't necessarily mean the treatment failed.
Exactly. It could just be leftover antigen from the successfully treated infection. For monitoring treatment response, microscopy is needed to see if live parasites are still present.
What about even more sensitive tests like PCR? Do they have a role in diagnosing individual patients?
Molecular diagnostics like PCR, polymerase chain reaction, are incredibly sensitive. They can detect very low density infections that both microscopy and RDTs might miss, and they are great for identifying mixed species infections. However, they currently have essentially no role in routine clinical management of individual sick patients in endemic areas.
Why not, if they're so sensitive?
They are generally too slow, too complex, require sophisticated laboratory equipment and highly trained staff, and are far too expensive for point-of-care diagnosis where a rapid decision is needed. Their real utility lies in research, in population-level surveillance, like tracking drug resistance markers or assessing prevalence in elimination settings, and in focused epidemiological investigations. Not for diagnosing Mrs. Banda who comes into the clinic with a fever today.
Okay, so diagnosis is key. Test everyone suspected, use RDTs or microscopy. Once malaria is confirmed, how is uncomplicated malaria treated? What's the standard of care now?
The cornerstone of treatment for uncomplicated P. falciparum malaria in almost all endemic countries worldwide is artemisinin-based combination therapies, or ACTs.
ACTs. Why are they the standard?
They replaced older monotherapies like chloroquine or SP because of widespread resistance to those drugs. ACTs are highly effective because they combine two active ingredients: a fast-acting artemisinin derivative like artesunate, artemether, or dihydroartemisinin, which rapidly reduces the parasite biomass.
Knocks down the parasite numbers quickly.
Exactly. And a partner drug that has a longer duration of action, a longer half-life, which stays in the body longer to eliminate the remaining parasites. This combination improves efficacy, makes treatment shorter, usually just 3 days, and critically helps protect both drugs against the development of resistance. It's much harder for the parasite to develop resistance to two drugs simultaneously.
Makes sense. What specific ACTs are currently recommended by WHO? Are there several options?
Yes, the WHO currently recommends 6 specific ACTs for uncomplicated P. falciparum malaria. These are artemether-lumefantrine, often abbreviated AL, artesunate amodiaquine, AS plus AQ, dihydroartemisinin piperacline, DHAP, artesunate mefloquine, AS plus MQ, artesunate plus sulfadoxine pyrimethamine, AS plus SP, although AS plus SP is less used now due to SP resistance, and a newer addition, artesunate pyroneuridine, ASPY.
And artesunate pyroneuridine, ASPY. That's the newest one on the list.
Yes, it was added more recently. Studies have shown it has non-inferior efficacy compared to other standard ACTs like AL or DHAP. It offers another valuable option, especially in areas where there might be concerns about resistance to the partner drugs and other ACTs.
But are there any special considerations or caveats for using ASPY?
Yes, there are important considerations. ASPY should generally be avoided in individuals with known significant liver disease, and programs using it need to implement strengthened pharmacovigilance, meaning very close monitoring for drug safety in the population, because there has been an association observed with transient, usually mild, elevations in liver enzymes, what we call transaminitis. So careful patient selection and monitoring are needed.
And the treatment duration for all ACTs is typically 3 days.
Yes, standard ACT regimens should always provide 3 days of the artemisinin derivative component. Some partner drugs might be dosed slightly differently within that, but the artemisinin part is key for those 3 days. Longer courses, maybe 5 or 7 days, might potentially be considered in very specific situations like documented treatment failure or in areas with confirmed artemisinin resistance, but the standard is 3 days.
Now, what about those special patient groups? Treating pregnant women or very young children must require extra care.
Absolutely. These groups require especially careful consideration due to differences in physiology, potential risks to the fetus or infant, and challenges with nosing.
So, pregnant women in their first trimester, what's the recommendation there?
For uncomplicated P. falciparum malaria in the first trimester, the currently recommended treatment is artemether-lumefantrine, AL. Other ACTs may be considered if AL is unavailable, but the data supporting AL use in the first trimester is growing. Quinine plus clindamycin used to be the alternative, but quinine treatment often has poorer outcomes, more side effects, and adherence challenges due to its longer course. Importantly, antifolate drugs like SP are absolutely contraindicated in the first trimester due to risks of birth defects.
And after the first trimester, second and third trimesters.
For pregnant women in their second and third trimesters, ACTs are generally considered safe and are the recommended treatment. There's now extensive data from clinical trials and observational studies showing no evidence of adverse effects on either the mother or the developing fetus when ACTs are used during this period. They are much preferred over quinine.
Okay, that's reassuring. Now, for the youngest patients, infants and small children, dosing must be really tricky.
It is tricky, and getting the dose right is critical. Young children and infants metabolize drugs differently and require precise weight-based dosing. For instance, the guidelines specify that children weighing less than 25 kilograms treated with DHAP should receive higher daily doses than previously recommended, a minimum of 2.5 milligram body weight of dihydrotemesinin and 20 milligram body weight of piperacine daily for 3 days.
Higher doses for smaller kids. That seems counterintuitive.
It does, but it reflects how their bodies handle the drug. They might clear it faster or have a different volume of distribution. Similarly, higher doses of parenteral artesunate are needed for children under 20 kilograms with severe malaria.
And the formulation matters too. Pills versus liquids.
Yes, pediatric formulations are strongly preferred, especially solid formulations like dispersible tablets, which can be dissolved in a small amount of water or breast milk. These are generally better than liquid syrups for ensuring accurate dosing, stability, and often better palatability and adherence compared to crushing bitter adult tablets. Liquids can be prone to dosing errors.
What about patients who have HIV/AIDS as well as malaria? That must add another layer of complexity.
It certainly does. HIV/AIDS co-infection poses significant challenges, primarily due to the potential for drug interactions between antimalarials and antiretroviral therapies, RP.
Give an example.
Sure. For example, the ACT artesunate amodiaquine, AS plus AQ, is generally not recommended for patients taking certain ART drugs, like efavirenz or zidovudine, because interactions can increase the risk of toxicity. Conversely, some ART drugs can reduce the levels of antimalarial drugs like lumefantrine, the partner in AL, potentially increasing the risk of malaria treatment failure or recurrence.
For close monitoring and careful drug selection are essential.
Absolutely. Health providers need to be aware of these potential interactions and select the ACT regimen carefully based on the patient's RT regimen. Close follow-up might be needed. It highlights the need for integrated care for co-infected patients.
In one more specific group, patients with a very high parasite count, hydroparasitemia. What's the concern there?
Patients with P. falciparum hyperparasitemia, often defined as parasites visible in more than 5–10% of red blood cells, are at significantly increased risk. Risk of treatment failure, even with effective drugs, risk of rapidly progressing to severe malaria, and risk of death. They require very close monitoring, often hospitalization, even if they initially appear uncomplicated. In addition to receiving their standard ACT treatment, they are considered to be on a knife edge.
Okay, so that covers uncomplicated P. falciparum pretty thoroughly. But what about treating the other types of malaria, the non-falciparum species, especially P. vivax, with this notorious relapse problem? How do the guidelines address that?
This is a critical area, and often more complex than falciparum treatment because of those dormant liver stages, the hypnozoites, found in P. vivax and P. oval. Treatment for these requires what's called radical cure.
Radical cure, meaning getting rid of everything.
Exactly. Targeting both the blood stages and the parasites causing the acute illness now and the liver stages to prevent future relapses.
So how do you treat the blood stage of vivax first? Is chloroquine still used?
It depends on the region. For chloroquine-sensitive P. vivax, which still exists in many parts of the world like Central America, oral chloroquine remains effective and is recommended at a total dose of 25 milligram base per kilogram over 3 days. However, chloroquine-resistant P. vivax is widespread, particularly in Southeast Asia and Oceania.
So for resistant vivax, what's used instead?
For chloroquine-resistant P. vivax, an effective ACT is the recommended treatment for the blood stage infection. Options like DHAP, artemether-lumefantrine, AL, or artesunate mefloquine, AS plus MQ, can be used depending on national policy and availability. DHAP, dihydrotemesinin piperacine, is often preferred where available, as the long half-life of piperacine provides a significant post-treatment prophylactic effect, helping prevent early relapses.
Okay, so that deals with the immediate illness. But then you need to tackle the liver stages, the hypnozoites, to prevent relapses. That's where primaquine comes in, right? And I recall you saying there was a significant update recently.
Yes, exactly. The standard drug for preventing relapse, the anti-relapse therapy, is an 8-aminoquinoline drug, most commonly primaquine. And there was a crucial update consolidated in the 2024 guidelines regarding the dose.
A higher dose.
Yes. For PVVAX or P oval relapse prevention, primaquine is now recommended to be given at a higher total dose of 7 millikilogram body weight. This can be administered either as 0.5 milligram kilograms daily for 14 days, or, importantly, as 1.0 milligram kilograms daily over a shorter 7-day course.
A 7-day course sounds much better for adherence. But is there a catch?
There's a very important catch. The shorter, higher-dose 7-day regimen, 1.0 millikilograms a day, is only recommended for patients who have been tested and confirmed to have normal or intermediate G6PD activity, specifically 70% of normal enzyme activity. For patients with lower G6PD levels, or where testing for that 70% threshold isn't reliably available, the longer 14-day course, 0.5 millikilograms a day, should still be used, provided they have at least 30% G6PD activity.
So G6PD testing is absolutely critical before giving the higher, shorter dose.
Absolutely critical. And it's worth noting the benefits of this higher total dose, 7 millikilograms versus the older 3.5 millikilograms scattered, can vary geographically based on parasite strains and relapse patterns. Local data should ideally inform policy.
Is there an alternative to primaquine for radical cure? What about tefenoquine?
Tefenoquine is another 8-aminoquinoline drug approved more recently for PVVAX relapse prevention. It has the advantage of requiring only a single dose. However, currently there's no direct comparative data between tefenoquine and the newly recommended higher dose, 7 millikilogram total primaquine regimen.
So it's hard to say which is better.
It is. Some limited data from Southeast Asia actually suggested that the older regimen of chloroquine plus 3.5 millikilogram primaquine performed better than chloroquine plus tefenoquine in preventing relapses in that specific region. So the choice between primaquine and tefenoquine often depends on national policy, availability, cost, and the feasibility of G6PD testing, as tefenoquine also requires G6PD testing and has stricter contraindications for deficiency.
This brings us back squarely to the G6PD deficiency hurdle. Why is this genetic condition such a major challenge for treating VVAX and oval malaria effectively?
The G6PD deficiency hurdle is arguably the single biggest obstacle to safe and effective radical cure globally. As we discussed, individuals with this common genetic deficiency affecting millions worldwide, especially in malaria endemic regions, are at risk of potentially severe hemolytic anemia if they take standard therapeutic doses of 8-aminoquinolines like primaquine or tefenoquine.
Their red blood cells break down.
Yes, the drugs trigger oxidative stress, and G6PD deficient red cells can't cope, leading to their destruction. This can range from mild anemia to severe life-threatening hemolysis requiring blood transfusions. It transforms a cure into a potential poison for a subset of the population.
So testing is essential. Are the available tests good enough for field use?
That's the crux of the operational challenge. Semi-quantitative near-patient G6PD tests exist now, providing rapid results in the field. The WHO guidelines express high confidence in the accuracy of these tests for identifying individuals with severe deficiency, often defined as 30% activity, who should generally not receive primaquine or tefenoquine standard doses. However, there's only moderate confidence in their accuracy for reliably distinguishing intermediate activity levels from normal levels, specifically around that 70% threshold needed to safely guide the higher dose, 7-day primaquine regimen.
So there's still uncertainty, especially for that shorter course.
There is. Programs face significant trade-offs between the costs and logistical complexity of implementing widespread, quality-assured G6PD testing versus the potential risk of harm to individuals if testing isn't done or isn't accurate enough. It's a classic public health dilemma.
What's the alternative for someone found to be G6PD deficient who needs relapse prevention? Can they get anything?
Yes. For individuals confirmed to be G6PD deficient, for example, 30% activity, the recommended alternative is weekly primaquine at a lower dose, 0.75 millikilogram body weight once a week, for 8 weeks. This regimen carries a much lower risk of severe hemolysis, but still requires close medical supervision.
And what if a pregnant or breastfeeding woman has PVVAX? Primaquine is out, right?
Absolutely. Primaquine and tefenoquine are strictly contraindicated during pregnancy and breastfeeding due to potential risks to the fetus or infant, especially if the infant's G6PD status is unknown.
So what do? Just treat the blood stage?
You treat the acute blood stage infection, usually with chloroquine, if sensitive, or an ACT considered safe in pregnancy. Then, to prevent relapses during the pregnancy, the woman can be given weekly chloroquine prophylaxis until delivery. This suppresses any parasites emerging from the liver but doesn't eliminate the hypnozoites.
And the radical cure happens later.
Yes, the full course of primaquine, after G6PD testing, can then be administered safely after the mother has completed breastfeeding. This careful staging protects both mother and baby while eventually achieving radical cure.
This really underscores the ongoing challenge of drug resistance, not just with p-falciparum, but potentially with 5-AX2, and the need for careful drug use. How do the guidelines address this constant battle to stay ahead of the parasite's evolution?
Drug resistance, including the emergence of resistance to artemisinin and derivatives and partner drugs and ACTs, is arguably the single biggest threat to recent gains in malaria control. Inappropriate use of anti-malarial medicines like incomplete courses, using monotherapies, using substandard or falsified drugs significantly accelerates its development and spread.
So monitoring resistance must be absolutely key.
Critical. The guidelines stress the essential need for routine monitoring of anti-malarial drug efficacy. This should happen through well-designed therapeutic efficacy studies, TES, conducted at least every 24 months at sentinel surveillance sites within a country.
What do these studies tell you?
They track how well the nationally recommended first-line and second-line treatments are actually working in curing patients. Early detection of declining efficacy allows countries to update their national treatment policies before widespread treatment failure occurs. Molecular monitoring for known resistance markers also complements this.
And beyond monitoring, how do the guidelines try to prevent resistance from developing or spreading in the first place? How do we optimize drug use?
Optimizing drug use involves several crucial strategies. Firstly, using combination therapies like ACTs, which combine drugs with different mechanisms of action, making it harder for resistance to emerge. Secondly, ensuring high cure rates through strategies that promote full adherence to treatment regimens, making sure patients take all their pills for the full duration.
How do you improve adherence?
Using fixed-dose combinations, FDCs, where both drugs are combined into a single tablet, is strongly recommended as it simplifies treatment and has been shown to significantly improve adherence compared to having separate pills. Patient education and counseling are also vital. Another important principle is trying to avoid using the same drugs for mass chemoprevention campaigns, like SMC or MDA, as are used for first-line treatment in the same area, if possible. This helps reduce the selective pressure on the treatment drugs. It's a constant strategic effort, a stewardship approach to preserve the effectiveness of our precious anti-malarial drugs for as long as possible.
It really is a strategic chess game against parasite evolution. Okay, let's shift gears to the most critical scenario. What happens when someone has severe malaria? This moves beyond routine outpatient treatment and into urgent life-saving care, correct?
Exactly. When malaria progresses to the severe stage, it becomes a true medical emergency requiring immediate and intensive care, usually hospitalization. Delay in treatment can be fatal within hours.
How is severe malaria actually defined? What are the signs clinicians look for?
The WHO guidelines provide clear clinical and laboratory criteria for defining severity, primarily for P. falciparum malaria, which causes the vast majority of severe cases. It's characterized by evidence of vital organ dysfunction. Key clinical signs include impaired consciousness or coma,
How is that measured?
often using the Glasgow Coma Scale, GCS, in adults. A score below 11 indicates severe, or the Blantyre Coma Scale, BCS, in children. A score below 3. Other major signs include severe prostration, inability to sit or stand without help, multiple convulsions more than 2 in 24 hours, deep breathing indicative of acidosis, circulatory collapse or shock, jaundice, abnormal bleeding, and pulmonary edema, fluid in the lungs.
And these signs must occur with confirmed malaria.
Yes, crucially, these signs must occur in the presence of confirmed P. falciparum parasitemia, usually detected by RDT or microscopy, and in the absence of an obvious alternative cause for the symptoms, like meningitis or sepsis. There are also laboratory criteria like severe anemia, hypoglycemia, low blood sugar, acute kidney injury, high lactate levels, acidosis, and hyperparasitemia itself. Any one of these signs in a patient with falciparum malaria qualifies as severe disease requiring urgent action.
Okay, that's a grim picture. What if a patient develops these signs in a remote area, far from a hospital equipped to handle severe malaria? Is there anything that can be done before they get transferred? A crucial first step.
Yes, absolutely. Pre-referral treatment is critical and can be life-saving, potentially preventing death during transport. Where complete treatment for severe malaria isn't immediately possible at the first point of contact, like a rural clinic or with a community health worker, a single dose of an effective injectable anti-malarial should be given before referring the patient to a higher-level facility capable of providing full management.
What drug is recommended for pre-referral?
The preferred drug is a single intramuscular IM dose of artesunate. If IM artesunate is unavailable, then IM artemether or even IM quinine can be used as alternatives.
What about for very young children? Are injections always feasible?
For children under 6 years old, if an IM injection is not available or feasible, rectal artesunate suppositories are a valuable pre-referral option. This buys crucial time, starts reducing the parasite load, and can stabilize the patient during what might be a long journey to the hospital.
That pre-referral step sounds vital. So once the patient reaches a facility capable of managing severe malaria, what's the first-line gold standard treatment?
For first-line parenteral treatment, meaning injectable, intravenous or intramuscular IM artesunate is strongly recommended, backed by high-certainty evidence.
Why artesunate over the older drug, quinine?
Parenteral artesunate is unequivocally superior to quinine for treating severe falciparum malaria in both adults and children. Large clinical trials have consistently shown that artesunate significantly reduces mortality compared to quinine by about 25% in African children, and by even more in Asian adults. It saves more lives.
Are there other advantages besides saving more lives?
Yes, artesunate is also generally easier to administer. It's given as a relatively quick IV push or IM injection at specific time points, 0, 12, 24 hours, then daily, whereas quinine requires a slow, controlled intravenous infusion over several hours, which is logistically more complex, requires infusion pumps or careful drip rate monitoring, and carries a higher risk of infusion-related side effects or errors, including potentially fatal overdose or hypoglycemia.
So artesunate is clearly the preferred choice. What if it's simply not available in a particular hospital or country?
If parenteral artesunate is genuinely not available, then parenteral artemether, usually given IM, is the recommended alternative. It may be superior to quinine, particularly in children over 5 years and adults, and is generally easier to administer than quinine infusion.
And quinine is the last resort.
Parenteral quinine remains an option only if neither artesunate nor artemether is available or if they are specifically contraindicated for some reason. However, quinine's supply can be erratic in some places. Managing its infusion is complex. It has a narrower therapeutic window, risk of toxicity, and it often requires co-administration with another drug like clindamycin or doxycycline once the patient can take oral medication, leading to a higher pill burden. So artesunate is really the standard everyone should be striving for.
Okay, so getting the right anti-malarial on board quickly is priority one. But severe malaria affects multiple organ systems. What other adjunctive medical management is crucial for these critically ill patients? It must be more than just the malaria drug.
Absolutely. Excellent supportive care is just as important as the specific anti-malarial drug. It truly requires a multidisciplinary team approach. Fluid therapy is critical but needs to be managed very carefully, especially in adults who are highly vulnerable to fluid overload, which can lead to fatal pulmonary edema. Fluids should be administered cautiously based on individual assessment of hydration status, urine output, and hemodynamic monitoring.
What about infections? Are severe malaria patients prone to other infections?
Yes, secondary bacterial infections like pneumonia or sepsis are common, particularly in children, and can significantly worsen outcomes. Therefore, broad-spectrum antibiotics should be given routinely to all children admitted with suspected severe malaria in moderate to high transmission areas, at least until bacterial co-infection can be reasonably excluded. This is a life-saving co-intervention.
And seizures. Cerebral malaria often involves seizures, right?
Yeah. Yes, seizures are common, especially in children with cerebral malaria. Prompt management with anticonvulsants is essential to stop the seizure and prevent further brain injury. Intravenous or rectal benzodiazepines like diazepam or lorazepam, or sometimes intramuscular paraldehyde are used.
What about other supportive measures? Blood transfusions.
Blood transfusion is often necessary to treat the severe anemia that frequently accompanies severe malaria. Monitoring blood glucose is vital, as hypoglycemia is common and dangerous, requiring 5e glucose administration. Careful monitoring of respiratory status, kidney function, and level of consciousness is ongoing.
I've heard of exchange blood transfusion being used in very extreme cases, like super high parasite counts. Is that a recommended practice in the guidelines?
That's a controversial area. While there have been anecdotal reports and case series suggesting a potential benefit from exchange blood transfusion, essentially removing the patient's blood and replacing it with donor blood to rapidly reduce parasite load and remove toxic metabolites, there have been no adequately powered, randomized controlled trials to definitively prove its efficacy or compare it to standard care with artesunate. Consequently, there's no consensus among experts on whether it consistently reduces mortality, and it carries significant risks and resource implications. Therefore, It is not routinely recommended in the WHO guidelines. Artesunate is so effective at rapidly clearing parasites that the rationale for exchange transfusion is much weaker than it might have been in the pre-artesunate era.
Got it. So focus on prompt artesunate and excellent supportive care. Lastly, what about severe non-falciparum malaria? Does that happen? And is it treated the same way initially?
While much less common than severe falciparum malaria, severe illness can occasionally occur with PIVavax, especially in areas like Papua New Guinea and Indonesia, and even sometimes with P. lacei. The clinical manifestations can mimic severe falciparum malaria.
So the initial management is similar.
Yes,
Mhm.
the principles of prompt, effective anti-malarial treatment and rigorous supportive case management should follow the same guidelines as for severe P. falciparum malaria. That means using parenteral artesunate as the first-line treatment. After the patient has recovered from the acute severe phase and can take oral medication, they must then receive a full course of radical cure treatment appropriate for the species, for example, including primacrine or tafenoquine after G6PD testing for PIVavax to prevent relapse.
That's a truly comprehensive approach, covering everything from the crucial first response in the field of pre-referral treatment to intensive care and supportive management in the clinic. It highlights how far we've come in managing this deadly complication. We've covered a huge amount, understanding the disease, prevention through vector control and chemoprevention, diagnosis, and treating both uncomplicated and severe malaria. Now let's talk about the end game: elimination and preventing reestablishment of transmission once it's gone. This sounds like where the fight gets incredibly granular, really strategic, and probably quite challenging. What are some of the mass strategies that get employed in this final push?
Right. As countries get closer to elimination or are working to prevent malaria returning after elimination, the strategies often shift towards finding and clearing every last infection. Mass strategies represent broad brush approaches applied to defined geographical areas, aiming for a community-wide impact. One such strategy that has been explored is mass testing and treatment, or MTT.
MTT, what does that involve? Testing everyone.
Essentially, yes. It involves attempting to conduct parasitological testing, usually with RDTs, on the entire population within a delimited geographical area, and then immediately treating all individuals found to be positive with an effective anti-malarial medicine. The idea is to find and clear all infections, including asymptomatic ones, simultaneously.
Sounds incredibly thorough, like a massive community sweep to clear out the parasite reservoir. Does it work? Is it recommended?
It sounds logical, but the evidence is not very supportive. While one study in Zambia did find MTT to be potentially cost-effective in their specific context, around US $804 per daily averted, and suggested it might enhance health equity by reaching underserved populations.
Right.
But the overall impact on reducing malaria incidence across several studies was generally judged as likely trivial or very short-lived. Moreover, MTT comes with very high operational costs and significant logistical challenges. Imagine trying to test and potentially treat everyone in a district within a short time frame.
What other issues came up?
Concerns were raised about community acceptance testing. Asymptomatic people can be difficult, sometimes leading to fears about other types of testing, like covert HIV testing. Adherence to treatment among those who test positive but feel well can be low, and even health workers sometimes express concerns about lost income from routine patient visits if MTT replaced standard care. So considering the high costs, logistical hurdles, and limited evidence of sustained impact, MTT is generally not recommended by the guidelines for routine use in elimination settings.
Okay, so MTT is largely out. What about mass drug administration? MDA, which we discussed earlier as a chemoprevention tool. Does it have a role in elimination settings?
MDA, giving drugs to everyone without testing, is another mass strategy sometimes considered. As we discussed, it might have a role in specific situations like emergencies or maybe for very rapid short-term burden reduction. However, for achieving or maintaining elimination, particularly in the post-elimination phase, MDA is typically not recommended unless there's clear evidence of local transmission resuming.
Why not for elimination?
Again, due to the high resource demands, logistical complexity, concerns about sustainability of impact, potential contribution to drug resistance, and the fact that more targeted approaches are usually preferred and considered more efficient in these very low transmission or zero transmission settings, the focus shifts from mass approaches to finding the needle in the haystack.
Okay, so if broad mass strategies like MTT and MDA are generally not the preferred tools for the final elimination push, what are these more targeted strategies that focus on specific high-risk individuals or groups? These sound more precise, more surgical.
They are indeed designed to be more precise. These strategies become crucial as transmission drops to very low levels. One key approach is targeted drug administration, or TDA.
TDA, how does that differ from MDA?
TDA involves providing a full therapeutic course of antimalarials, but only to specific individuals or well-defined groups, identified as being at significantly increased risk of acquiring or transmitting malaria. This could be based on their occupation, for example, forest workers, miners, specific behaviors, example, frequent travel to endemic areas, or living conditions. The goal is to reduce community transmission by curing existing infections and preventing new ones, specifically within this high-risk reservoir, which might be driving residual transmission.
How does TDA compare to MDA in terms of implementation and feasibility?
TDA is generally considered potentially more equitable if the groups are identified fairly, more acceptable to the wider community as not everyone is being medicated, and more feasible logistically than trying to reach everyone with MDA. This makes it particularly suitable for very low transmission or post-elimination settings, provided that these high-risk groups can be clearly and reliably identified without causing stigma or discrimination.
So it's about being incredibly precise with resource allocation, focusing fire on the key transmission hotspots or groups.
Exactly. It's a smart way to potentially get maximum impact from limited resources when transmission is already very low and focal. Focus on the people most likely to be carrying or importing the parasite.
And following the same logic, what about targeted testing and treatment? That sounds like an even more refined version, testing the high-risk groups first.
Yes, targeted testing and treatment, or TTT, is similar to TDA, but involves first screening these identified high-risk individuals or groups with a diagnostic test, like an RDT, and only treating those who test positive for malaria infection.
What are the potential advantages and disadvantages of TTT compared to just treating everyone in the target group, TDA?
PTT might improve adherence to treatment. People are more likely to take medicine if they know they're infected. Enhance population acceptance, less concern about unnecessary medication, and further improve equity by only medicating confirmed cases. It also reduces drug pressure and potential side effects compared to giving drugs to everyone in the group. However, the added step of testing adds complexity and cost. And importantly, the current evidence on the overall balance of effects and the cost-effectiveness of TTT is still quite uncertain.
So what's the recommendation for TTT?
Given the uncertain evidence base, TTT is currently conditionally recommended against for routine use in very low-to-low transmission settings, pending further research to clarify its impact and value compared to TDA or other strategies. The added complexity and cost might not always be justified by the potential benefits.
Okay, another key aspect of elimination and preventing reestablishment must be stopping malaria from being reintroduced from outside after a country has successfully eliminated local transmission.
Ooh.
How do the guidelines address this challenge of importation prevention?
This is absolutely vital. Countries that have achieved elimination or are very close become highly vulnerable to malaria being brought back in by infected travelers or migrants coming from areas where malaria is still endemic. This can easily spark new local outbreaks if not managed.
So should countries just test everyone arriving at airports or border crossings?
That might seem intuitive, but the guidelines specifically advise against routine screening or testing of all travelers at formal points of entry like airports, seaports, or major land borders.
Why not? Seems like a logical control point.
Several reasons. Studies evaluating this approach found no clear evidence of significant impact on reducing importation. Plus, it's generally considered unlikely to be acceptable or feasible on a large scale. Imagine the logistics and cost of trying to test every single person arriving internationally. You'd face high refusal rates due to time constraints, fear of needles, perceived low personal risk, and it would likely be incredibly inefficient, requiring thousands of tests to find one case. It's just not a practical or effective use of resources.
So no blanket testing at airports. But are there more targeted approaches for importation prevention that are recommended? Can you screen specific groups?
Yes, there are more targeted recommendations. The guidelines conditionally recommend testing and treating specific, organized, or identifiable groups of people arriving or returning from malaria-endemic areas. This applies particularly to areas approaching elimination or those working to prevent reestablishment after elimination.
What kind of groups are we talking about?
Examples might include large groups of migrant workers arriving for seasonal labor, refugee populations being resettled, military personnel returning from deployments in endemic zones, or perhaps specific communities known to travel frequently to high-risk areas. If these groups can be easily identified and accessed shortly after their arrival.
Then testing and treating positives makes sense.
Yes. Testing them, for example, with RDTs, and ensuring prompt, effective treatment for any confirmed cases can significantly reduce the number of imported infections entering the community. The feasibility and success depend heavily on being able to access these groups efficiently and having good engagement and cooperation. It's about targeted surveillance and response at the source of importation.
That's a very practical, almost epidemiological, intelligence-driven approach. Now, let's talk finally about reactive strategies. These sound like rapid responses triggered after a malaria case is detected, a kind of immediate containment effort. How do they work?
Exactly. Reactive strategies are all about quickly responding to a locally acquired or imported malaria case to prevent it from leading to further onward transmission in the community. Acting like a fire brigade, putting out sparks before they spread, one approach is reactive drug administration, or RDA.
RDA. What does that involve? Treating contact.
Yes. It involves providing a full therapeutic course of anti-malarial medicine to people residing with or very near to a confirmed malaria index case, the first case detected, or sometimes to others who might share the same risk exposure, like co-travelers or co-workers if the case was likely infected elsewhere. The idea is to treat any potential secondary infections in these close contacts before they become symptomatic or infectious themselves.
What capacity does a program need to implement RDA?
Programs need strong surveillance systems to detect index cases quickly. Then they need the capacity to conduct rapid case investigations to determine where the infection was likely acquired and to identify, enumerate, and locate these close contacts for treatment.
And community engagement must be absolutely key for RDA.
Yeah.
Especially giving drugs to people who probably feel perfectly healthy.
Absolutely crucial. Gaining community trust and acceptance is paramount for RDA to be successful. People need to understand why they are being asked to take medicine when they don't feel sick. Clear communication about the purpose, preventing further spread, and addressing concerns about potential side effects are essential. Without community buy-in and good adherence among asymptomatic contacts, RDA is unlikely to be effective.
Okay, so RDA is treating contacts. What about actively looking for other cases around the index case? Kind of magnifying the search.
That's reactive case detection and treatment, or RACDT. This strategy involves actively screening people living within a defined radius, say 100, 500 meters, or a certain number of nearby households, around a confirmed index case using RDTs or microscopy, and then promptly treating anyone found to be infected.
So it's actively hunting for more cases triggered by the first one.
Yes. It aims to find and eliminate other infections in the immediate vicinity that might have resulted from the same source or from early local transmission. RACDT significantly strengthens surveillance and response systems, and it becomes increasingly essential as countries get closer to elimination, helping to stamp out residual transmission foci and prevent reestablishment.
What are the challenges with RACDT?
Challenges include accessing remote or mobile populations within the investigation radius, ensuring high-quality diagnosis, especially if relying on microscopy in the field, defining the appropriate radius for investigation, and managing the workload if many index cases are detected simultaneously. Properly managing imported cases through RACDT is also vital to prevent them from seeding local outbreaks.
And finally, can you do reactive spraying, like a targeted IRS response?
Yes, that's reactive indoor residual spraying, or IRS. This involves conducting IRS spraying the inside walls of houses with insecticide, but only in the houses of confirmed index cases and often their immediate neighbors within a defined radius.
What's the evidence for RRS?
Studies have shown that RIRs can contribute to reducing malaria prevalence in the targeted microlocality. It's often thought to be more readily accepted by households than proactive, routine IRS covering entire villages, because residents are acutely aware that a malaria case has just occurred nearby, making them more motivated to accept the intervention.
But there are trade-offs.
Yes. Programs must carefully balance the potential added benefits of IRS against the operational costs and, importantly, the potential contribution to insecticide resistance if used frequently or on top of existing proactive IRS strategies using the same insecticides. It needs to be part of a carefully considered integrated response strategy.
So it seems this final push for elimination requires a highly dynamic, incredibly targeted, and very responsive set of strategies. It's about constantly adapting, using local intelligence, and building on that solid foundation of robust prevention and effective treatment we discussed earlier. Wow. What an incredible deep dive we've had today. We've journeyed through the really complex and sophisticated world of modern malaria control, from the inventive designs of those next-generation ITNs,
Like the PBO nets and the chlorphenapir nets, yeah.
and the very precise targeting of chemoprevention for pregnant women and kids, to the absolutely critical importance of accurate diagnostics and tailored treatment regimens for everything from straightforward, uncomplicated cases to life-threatening severe malaria.
And then right through to those granular reactive efforts required to actually eliminate the disease and keep it out. It's a huge spectrum of activity.
It's clear that malaria is still a formidable foe, isn't it? Constantly adapting, throwing up challenges like resistance. But it's also clear that consistent scientific effort and public health adaptation are truly making a difference.
Definitely. These consolidated WH guidelines we've been discussing really lay out a comprehensive yet highly dynamic roadmap. It's not static. It's designed to evolve as the evidence evolves, as the parasite evolves, as the mosquitoes evolve.
And what truly stands out to me, the unifying message perhaps, is that there's no single silver bullet. There's no one magic solution.
Not at all. The fight against malaria is fundamentally a dynamic, multifaceted endeavor. Success relies heavily on using local data effectively, adhering to rigorous scientific evidence, and having a deep understanding of the complex interplay between the parasite, the vector, the environment, and human populations and health systems.
From the promise of new vector control tools like those spatial emanators to the very practical, almost mundane challenges of insecticide disposal or ensuring people complete their ACP course, every single aspect is being carefully considered.
Indeed. The guidelines consistently underscore the importance of things like continuous monitoring for drug and insecticide resistance. You have to know what you're up against. Tailoring interventions to specific subnational contexts, using local data, no more one-size-fits-all, and addressing the unique needs of vulnerable populations like pregnant women, young children, and maybe specific occupational groups.
In the evolution of treatment protocols, like the higher primocane doses for Vivax radical cure and all the careful considerations around G6PD testing, it really reflects that ongoing refinement, doesn't it? A continuous arms race against the parasite, informed by better science.
It really does.
So for you, the listener, we hope this deep dive has equipped you with a much more nuanced understanding, hopefully going far beyond the headlines, of the sheer strategic ingenuity and persistent effort dedicated to protecting millions from this devastating disease. It's not just about a few tools, but how this entire ecosystem of interventions is deployed, adapted, monitored, and refined, constantly striving towards that ultimate goal of a malaria-free world.
And this continuous evolution of the guidelines, the constant search for new tools and better ways to use the ones we have, it really speaks volumes about humanity's relentless pursuit of that goal. It's a testament to sustained global commitment and scientific resilience against a very old enemy.
So thinking about the future then, given all the complexities we've discussed today, from adapting to insecticide resistance and climate change impacts, to managing drug side effects like hemolysis with G6PD deficiency, ensuring equitable access in fragile settings, and funding it all, what do you think might be the next truly groundbreaking innovation that could tip the scales decisively towards malaria eradication? And perhaps more importantly, how might that innovation overcome the very real practical challenges we've highlighted? We've seen incredible progress. What will it really take to finally achieve zero malaria?